Good evening, all. We have always seen this hypertension is a very common case seen in any medicine OPD, but all hypertension is not the simple hypertension which we see as a lifestyle disease. Some are due to secondary hypertension. So today we have a case presented by an eminent speaker, Dr. Tom Jones. He has done his MBBS from Government Medical College, Thrissur, and MD from AIMS, Delhi. And he did his DM from PGI, Chandigarh. Also, he did his MRCP, UK recently. He is a native of Kottayam district and is presently practicing as a consultant nephrologist in Sreechand Hospital. I invite Dr. Tom Jones for the speech.
Good evening to all. First of all, I would like to thank the leaders of IMA Kannur for giving me a chance to present in this August audience again. This is my second time. And I would thank Manu sir for the kind introduction. He was my teacher in the MRCP UK training program at Kolancheri. So, first of all, I would like to tell a disclaimer. This is a very, very rare case of hypertension. So, but please focus on the approach and the different etiologies which we had thought of while we came into this conclusion. So this is a case of hypertensive emergencies. Another disclaimer is that it's not a happy ending, but the journey was important. So while I did my training at DM for DM at PGI Chandigarh, our most learning was happening on Wednesdays because our CPCR sessions were on Wednesdays, and that would be jam-packed because pathology and clinical correlation is the best way to teach and best way to learn. My patient is a 58-year-old male who was a businessman. He was the owner of a construction company, very affluent. In fact, he had constructed many hospitals in Kannur. And he was a diabetic patient with history of resistant hypertension. Resistant hypertension for almost 2 years because he was on almost 4 drugs and yet not very good control of hypertension. History of renal stone disease, and he had history of hypothyroidism. The list of drugs which he was on previously, that is nifedipine, telmisartan, carvedilol, moxonidine, isoleucine, almost more than 3 drugs, which is not one of which is not a diuretic, but because his output was almost nil, so his diuretic was withheld. So we'll come to the definition of resistant hypertension in our theory part. So he was a resistant hypertensive patient for almost 2 years, and he had history of left partial nephrectomy for a renal mass thought to be a renal cell carcinoma, which was 3 years back. And currently, he was a dialysis patient for 6 months duration at a periphery center. In fact, almost 4 dialysis machine was donated by this person. That was his financial status. He was under follow-up outside hospital. He was in a peripheral maintenance dialysis center. So his symptoms, which started, I'm referring back to November 2022. So he was having some symptoms of feeling of unwellness, higher BP than usual, fluctuating sugars of 1 week duration. He was taking insulin. He was taking all his medicines correctly. There was no non-compliance. And on 18th of November 2022, he had taken his night insulin dose, usually after monitoring his night blood sugars. His wife remembers that he was last seen normal at 1 a.m. when he had woken up for going to the bathroom. Then our story starts at 7 a.m. on 19th of November. He was found unresponsive. The relatives tell no history of trauma, no history of seizures, no history of vomiting. And we don't know what happened between this 1 a.m. and 7 a.m. So even after multiple response calling, he was found unresponsive, and they checked his blood sugars. They knew that probably his insulin was higher. His blood sugars were very low. They rushed him to the nearest hospital. It was near Iriti, and they also found the patient to be unconscious. They took the vitals, and his BP was 270 by 120 millimeter, and his blood sugars were below 70 milligram. They immediately started him on IV dextrose infusions and also IV NTG infusions as an IV for immediate BP control. Continuous infusions were continued, but due to the low GCS, to protect his airway, he was intubated by the physician, and he was rushed using a mobile ICU to our hospital. On receiving at our emergency department, his BP was around 260 by 100 millimeter mercury, and his GRBS was 74, and GCS was E1, VT, and M1. So we immediately thought of a IC bleed due to high BP and a low blood sugars due to high insulin dose. That would be the most common thing in a dialysis patient like this. And we shifted him to the intensive care unit. So at that time, our provisional diagnosis was a dialysis patient with a hypertension, high blood sugars, hypertensive emergency with altered sensorium, intracranial bleed, and hypoglycemia due to insulin overdose. Hypertensive emergencies because it was a very high BP, more than 180, 110, and with end organ dysfunction, that is his altered sensorium. For as a nephrologist, usual dialysis patient with any pulmonary edema or any uncontrolled BP, usually we get BP more than 200 in many patients, which get controlled with dialysis. But this was not the scenario in this patient. And his CT didn't show any bleed. So he was in the medical intensive care unit. His BP was still in the same level of 270 in spite of the infusions, and his blood sugars was still less than 70 in spite of the multiple dextrose infusions. So we shifted to labetalol infusion because we thought of that NTG might not be good for a altered sensorium patient because it might raise the intracranial pressures. So labetalol would be a better choice at that time. We put the central line for the IV inotropes infusions, and we put the arterial line to confirm the BP is correct. Again, on infusions with the labetalol, his BP dropped to 100 by 60, and we had to withhold the labetalol, and blood sugars rose up to 264 milligram. The hypotension and bradycardia worsened, and he was having recurring movement of atropine and noradrenaline. Again, his BP rose up to 210, and we had to stop the noradrenaline. And GRBS again became low, and we had to restart the dextrose infusion. This was going on a cycle mode. Again and again, we are doing the same things. And almost a seesaw pattern. You can see the BP monitoring. It was a fluctuating BP with very high and very low recordings. So I told this is a hypertensive emergency. Why it's a hypertensive emergency? We will go with the theory along with the presentation. So hypertensive emergency is a patient who has a high BP greater than 180 and with a diastolic greater than 120 with end organ dysfunction. So if it is end organ dysfunction, we'll come list out later. If it is lower without end organ dysfunction, it is asymptomatic, markedly elevated blood pressure, formerly called as hypertensive urgency. So it's defined by severe increase in blood pressure associated with acute hypertension mediated organ damage, AHMOD, to heart, brain, retina, kidney, and large artery. Heart can lead to pulmonary edema, brain can lead to intracranial hemorrhage, retina, there can be retinal hemorrhages, kidney, there can be thrombotic microangiopathy due to very severe high BP. It can lead to acute kidney injury. Large arteries, aortic dissections can occur. But the most frequent clinical presentations can be seen by all of us. Like can be leading to stroke in 38%, pulmonary edema 35%, and coronary syndromes. So the neurology, cardiology, and also the physicians with critical care interest will have experience of hypertensive emergencies which present like this. The main thing which we should think of while managing such a patient is that BP reduction should be gradual. We learned that in our MBBS time that in an IC bleed, if you reduce the BP less than 170, 160, it might lead to reduced intracranial perfusion and more brain damage. So mainly without compromising the organ perfusion and based on the specific indication, we should target our BP. Usually, essential hypertension patients with non-adherence to medication is the most powerful cause of this hypertensive emergencies. And one thing I mentioned previously, NTG infusions are contraindicated in hypertensive encephalopathy as venous vasodilation leads to raised intracranial pressure. This was a new knowledge for me also. This I learned during managing this patient only. So this patient has elevated BP and with end organ damage. So usual blood reports which we do are the CBCs, the creatinine, sodium, potassium, and also LDH for any hemolysis, ECGs, fundoscopy, etc. for the end organ damages. So these are the main classification which we can think of. The heart, it can lead to coronary syndromes, pulmonary edema, aortic dissections. The kidney, I already mentioned the TMA, acute renal failure, ischemic stroke, intracranial hemorrhage, and hypertensive encephalopathy. Even posterior reversible encephalopathy syndrome is also a possibility. And also for females, pregnant ladies, preeclampsia and eclampsia is also a hypertensive emergency. So different organ systems can be affected and the investigations which follow are based on specific organs. So broadly speaking, the end organ dysfunctions can be, if there is a ripping or tearing chest pain, you should think of aortic dissection. Chest pain, angina. Pulmonary edema, it could be volume overload. And also focal neurological deficit due to stroke. Altered mental status, like in our patient, it could be hypertensive encephalopathy. Seizures due to high BP. And also some hemorrhages, oliguria, elevated creatinine. These are the usual end organ dysfunction which we think of. So these are the specific syndromes and how do we treat this? So the target BP is usually around the range of 160. Usually we target the BP reduction by around 20 to 30%. And you can think the treatment as mainly this aortic dissection and acute myocardial infusion. They usually treat with labetalol because it's a beta blocker. IV infusions can be given. Nitroglycerin is also good for heart. So pulmonary edema also nitroglycerin comes in top. Acute renal failure, we can use any of this. Encephalopathy, as I mentioned, anything CNS, NTG is not there in the list. So mainly slow tapering of BP to around 160 range. We can use either usually available labetalol or nitroglycerin or nitroprusside infusion, which are usually available in our hospitals. This is if the patient is not responding to any oral medications and it's a case of emergencies. So currently in our patient, back to our patient, what were the issues which we were having? We were having a hypertensive emergency which was fluctuating. One time the BP was 240, one time BP was 100. We were having very difficulty in tapering and controlling and maintaining the BP. The other issue was the refractory hypoglycemia and also the altered sensorium, for which we couldn't find any specific cause till that time. So we sat up in the medical ICU. It was time was around night time. So we took up our laptop and did the literature review in front of that patient because we were not finding any diagnosis, because we are unable to explain to the relative also what was happening to the patient. So most probably this is a case of secondary hypertension because the BP of 260 by 110, new onset to hypertension, we can't explain by an essential hypertension. The patient is already on many medications and the medications were already taken, no non-complaints. Probably this is a secondary hypertension. So secondary hypertension, which are the usual causes which we think of? Cushing's, OSA, hypothyroid, hyperparathyroid, coactation, pheochromocytoma, Cushing syndrome, CKD. So these are the usual secondary hypertensions which can present with high BP. But in this patient, already he's a dialysis patient, and his dialysis was on regular schedules. He didn't miss any dialysis session. So CKD and kidney disease causing all this is very unlikely. And fluctuating BP and also some sugar issues. So OSA was not there in the patient clinically situation. Cushing's disease was not at all from the history. There was no clinical appearance of Cushing's. His thyroid functions were previously done. Everything was normal. And his pulses all were palpable. No BP deficit or discrepancy between the upper limb or lower limb. There was no coactation. So, and potassium was also normal. Hyperaldosteronism leads to hypokalemia. So the only thing that was left was pheochromocytoma. So the thing to do was this 24-hour urine metanephrine and plasma-free metanephrine. We have already learned about all this in our MBBS time as a rare thing, which we usually don't do in our clinical practices. But to our surprise, this specific patient has already been evaluated for all this. In August 22, in a prior hospital, someone had thought that this patient is having a very uncontrolled BP and he needs to be evaluated for secondary hypertension. So the usual causes, renovascular hypertension, for which someone had a renal Doppler, which was not normal. The plasma aldosterone renin ratio, which is usually high in the this primary hyperaldosteronism, that was also normal. And plasma metanephrine has already been done in this patient, and that was also normal. So why would we think of pheochromocytoma? But in all the tests and all the diagnosis which we had, only thing that can be falsely normal was this pheochromocytoma. So we just thought of that in our back of mind. And just we were reading in the up-to-date, there is something called pheochromocytoma multisystem crisis. It causes hemodynamic instability with severe hypotension and hypertension, labile hypertension, high temperatures, encephalopathy with multi-organ failure, and can be confused with septic shock, thyroid storm, or malignant hyperthermia. So something was fitting this patient because he was in BP and sensorium was issue and very high BP. So we thought that this could be a possibility, pheochromocytoma multisystem crisis, which we were learning for the first time at that time only. Refractory hypoglycemia. So if you ask a MBBS student, what is the cause of refractory hypoglycemia, you would tell insulin overdose. And second cause, in our theory, we will learn about insulinoma. Insulinoma leads to refractory hypoglycemia. So we just thought of insulinoma, the pancreas, malignancy from the pancreas, which leading to high insulin and reduced sugars. But this tumor-induced hypoglycemia, only one cause is insulinoma. This insulinoma was not fitting this patient because there was the high BP, possibility which we were thinking of pheochromocytoma, two malignancies together. So the second thing that was coming up in the list was this thing, non-islet cell tumor ectopic insulin production. That is an ectopic malignancy which produces insulin. So that could be something that which we can think of as a very far-fetched idea in this patient. So very two rare diagnoses which we had at that time, that was pheochromocytoma multisystem crisis with non-islet cell tumor hypoglycemia. So one rare diagnosis is very rare. Having two rare diagnoses together is very, very rare. So, but there was, we searched the literature, there was one or two case reports that hypoglycemia due to ectopic release of insulin from a paraganglioma. Paraganglioma is another word from pheochromocytoma. So there has been some cases in which there is a retroperitoneal small tumor which secretes this high insulin and also this metanephrine and normetanephrine, leading to hypertensive crisis. So we had a possible explanation for all the things which we had. So, but actually we were like this only. It's a house of cards only. We were having many assumptions and very rare possibilities. And finally we made an assumption and leading to a rare diagnosis. That was our situation at that time. And we had a very unstable patient. No lab test, no nothing conclusive at that time. And we had very worried relatives outside our ICU. That was a situation around night time. So how to proceed now? That was our question. All the literature review, all we had. confirmation needed a CCT to prove that there is something, a malignancy like that. But the patient was unstable. So we thought that first we will treat and first we will stabilize and then we will shift for imaging. So we just read about this tumor hypoglycemia. The treatment modalities are glucagon, steroids, human growth hormone, etc. And also pheochromocytoma, we can try nitroprusside. So we also read about the management of pheochromocytoma. So in such a patient, usually medical stabilization is with alpha blocker followed by beta blocker. You give prazosin, then propranolol, and you should stabilize the patient. That is for a stable pheochromocytoma patient. But ours was not a stable patient. It usually leads to adrenalectomy in urgent cases. That was our definitive treatment. So our patient was having BP of 160. The labetalol was withheld. He had hypotension bradycardia. Again, the noradrenaline was given, fluctuating BP. Pupils were reacting. Spontaneous breathing was present, but the patient had focal onset seizures also. So this was a very worrying thing because already we were very worried that the patient's brain damage would have started and he was having some focal seizures. So at that point, our doubt was whether we should evaluate and treat or whether we should leave this patient. So we discussed this with the relatives. Actually, this patient had 2 daughters, married, and the decision makers were 2 son-in-laws. Actually, I already previously explained his financial status and everything regarding that. So this patient's relatives had no issues with the money. And actually, they wanted to do everything and anything possible to save the patient or at least know what happened to this patient. So they told us, doctor, you do whatever you want. We will support you to any extent. We will provide any medicines that is rare medicines anywhere in the world. We will help you. So we went ahead, knowing well that there might be poor neurological outcome in this patient. So we sent out all his investigations in fasting insulin, C-peptide, thinking of the insulinomas, plasma-free metanephrine and normetanephrine again. And also we started to sodium nitroprusside, dexamethasone IV, octreotide, glucagon boluses. Glucagon boluses, only one was available in this hospital. So we called upon MIMS pharmacy. They helped with some district hospital Kannur. They also had some hypo kit for insulin overdose, glucagon. Human growth hormone, we arranged with the Novo Nordisk insulin company. They were also helping. So everyone was helping and we were trying to stabilize his blood sugars. We needed to stabilize him also with a slow dialysis in the ICU. And almost the patient became stabilized and we planned for CCT. So the CCT image was like this. Single contrast exposure itself, our radiologist told that, sir, there is something in the retroperitoneum. It is enhancing on contrast administration. It's a soft tissue density. It is posterior to the duodenum with contrast enhancement, possibly a paraganglioma. That was the radiologist report on by phone, even without us telling anything. So we were very happy. Actually, we had made a very, very rare assumptions and we saw something in the CT. So back to the management protocol, unstable patient, treatment is difficulty in controlling multi-organ failure, urgent adrenalectomy. So this was a Sunday and we have an intubated patient on sometimes noradrenaline, sometimes NDG infusions with fluctuating sugars, intubated, poor neurological outcome, and we need an adrenalectomy. So I called upon our gastrosurgeon, Dr. Samesh Patman. He was very supportive and he told that you take the pre-anesthetic checkup and the cardiology clearance, I will go ahead with the surgery. So we took high risk consent for cardiology clearance and even death on table consent. Our thought process was that you remove this causative thing and his BP and sugars will get controlled and we might be able to give him a neurological outcome and save the patient. That was our thought process at that time. We went ahead with the surgery and he demonstrated that posterior to the duodenum, there was something that was removed. It was a very well-defined mass lesion behind the duodenum. And this is the cross-section from the pathology. Near to the adrenal gland, we can see that yellow, well-encapsulated tumor thing. And on microscopy, you can see the adrenals and the tumor which are two morphologically different things. And on microscopic examination, they had commented us it's an encapsulated neoplasm composed of cells arranged in nest, cord, and solid pattern, small to large size with abundant pale granular, some with clear and eosinophilic cytoplasm. So they had mentioned as adenoma, but the IHC staining was not done. So we can finally tell that this is paraganglioma, but probably it's a paraganglioma only. And the blood reports which we had sent, the plasma normetanephrine was very high. And also the insulin levels were 126. And post-surgery, his levels had come to 33. So we had made the diagnosis. It was a dialysis patient with diabetes, hypertension, with hypertensive emergency, with pheochromocytoma multisystem crisis, which I was learning at that time only, with insulin secreting paraganglioma. This is the BP chart, all came to normal. And the blood sugar chart, you can see the top rows are all 60s and the bottom rows are all 300. So the monitoring chart itself showed that the treatment was definitive. There was response to our treatment. But the sad story was that his GCS didn't improve. So the neurologist took up his MRI and already there was T2 flare bilateral symmetrical hyperintensities in the cerebral cortex and basal ganglia, hypoglycemic brain damage. So in my first slide, I had told we don't know what happened between 1 a.m. and 7 a.m. It was almost 6 hours, and we don't know how much long the patient was in hypoglycemia. So from the time we had got the patient, we had tried to maintain everything, but we don't know what happened prior to that. So the relatives gave consent for do not resuscitation, and the family was planning for palliative therapy, discharged to a peripheral hospital, where he succumbed to aspiration pneumonia on day 23 of his initial presentation. So on retrospective thinking, I strongly feel that his resistant hypertension was due to a pheochromocytoma only. And what we learned in our MBBS time as a episodic hypertension is not always true. Pheochromocytoma can have almost in 50% of patients chronic resistant hypertension, and it led to hypertensive nephrosclerosis, and it led to end-stage renal disease and became a dialysis patient. So on 2 years, he was on follow-up of many doctors, but we didn't understand that this patient had pheochromocytoma. And if we had removed that tumor prior, he wouldn't have his kidney disease at all. So that's the clinical story. Resistant or difficult to control hypertension is a topic from an NEJM article, which I found very important while I started practicing, because many patients doesn't get controlled with our usual 1 or 2 antihypertensives. And resistant hypertension, by definition, the BP that remains above goal despite adherence to treatment with full doses of at least 3 antihypertensive medication, one of which is a diuretic. That's a definition for resistant hypertension. And that means if your patient is controlled with 4 drugs, that's also a resistant hypertension, like in our patient. But everything is not always secondary hypertension. There can be pseudo-resistant hypertension also. Sometimes it might be due to white coat effect. You might need an ambulatory BP monitoring, poor adherence to the drugs, and also improper office measurement, and also cuff size issues, and also elderly patient that be this brachylatory calcifications, all can lead to pseudo-resistance. But most of the time, our most important focus comes to secondary hypertension when you deal with resistant hypertension. So it is the main thing about secondary hypertension is that it is usually unmanageable until you identify the correct cause. Around 10% of patients with resistant hypertension had secondary hypertension, and it is more common in elderly patients, and it's our usual causes. We had already dealt with this in our cases. It's obstructive sleep apnea is a very common case, which we don't think of many times. If you correct the sleep apnea using a BiPAP machine, and his BP might get better control. And renal parenchymal disease. For us nephrologists, resistant hypertension is very common. Kidney disease is an end result of hypertension, and is also a very causative thing for resistant hypertension. Primary aldosteronism. This we learned in our MBBS as one of the endocrine cause of hypertension, but actually in practice, it is told that prevalence is almost up to 15%. Now many studies are coming that this is very underdiagnosed, and also we should do potassium monitoring and also plasma aldosterone renin ratio and also imaging to understand whether it's a primary aldosteronism. Such patients respond very well to just an aldactone, spironolactone 25 or 50 milligram. And we can taper off many drugs which the patient was already having. Renal artery stenosis. Usually in our general practice, when we have a difficult to control hypertension, the first thing we do is a renal artery Doppler. But actually, it's only less than 8% of the cause of secondary hypertension. So it's not very much common. And actually, we would, unless there is some specific clinical situations, like an elderly patient, features of atherosclerosis already, smoker, coronary artery disease, peripheral vascular disease, discrepancies in the pulses, young female patient with difficult to control hypertension, you're thinking of a fibromuscular dysplasia, or a patient who started with a telmisartan and rapidly his renal function worsened. A renal artery stenosis patient, if you double artery, if you're starting on telmisartan, his creatinine will rise rapidly. So all this clinical situation, and also some patients of flash pulmonary edema, all these are suggestive of renal artery stenosis. And also you do an ultrasound, one kidney is 10 centimeter, one kidney is 6-7 centimeter. So discrepancies maybe due to renal artery stenosis. So in such situations, a Doppler will be more effective. But the issue is that even if you find a renal artery stenosis, in an atherosclerotic case, you won't do much. The role of angioplasty is very debatable in an atherosclerotic renal artery stenosis. Young female fibromuscular dysplasia, there is good role of angioplasties. Rare causes, our patient, pheochromocytoma, I already told, the episodic flushing, hypertension, sweating, tachycardia, and you do the plasma metanephrine, normetanephrine, or 24-hour urine metanephrines. Cushing's disease, you do the serum cortisol or dextromethasone suppression test. Hyperparathyroidism, high calcium, high PTH value, you screen the ultrasound, you get an adenoma, you remove that, the patient is cured. Coactation, you get difference in the upper limb and lower limb BP and all the pulses, you get a bruit, might be a coactation, and intracranial tumor, very rarely. So if you get a resistant hypertension and you ensure the adherence, you ensure the white coat hypertension is not there, you ensure the proper measurement, and still if you are thinking of high BP, you should think of the rare causes and find the diagnosis, because it might be a rare thing, but in that patient it is 100%. So if you remove that 100% thing, that patient is cured for life. Being a nephrologist, I should specifically tell that CKD is a very common cause and complication of poorly controlled hypertension. And very sadly, we admit that less than 15% of our patients get controlled BP. Dietary sodium restriction is very important in a kidney patient, and diuretics is very important in the management of a CKD patient with hypertension. And in initial stages of the kidney disease, ACE inhibitors and ARBs are very good choices. So how do we approach a resistant hypertension? You confirm the treatment resistance. If it is more than the target, that is the 140/90 in our general population, or greater than 130/80 in a diabetic or CKD patient, which is the target is lower in them. And that patient needs 3 or more antihypertensive medication at optimal dosages, including a diuretic. So exclude the pseudo resistance, ensure the lifestyle factors are corrected, obesity, exercise, alcohol, remove the high salt, rule out that any other confounding drugs are not there, like NSAIDs, OCPs, any drug abuse, etc. All that can lead to high BP. And how do we screen for the secondary causes? Obstructive sleep apnea, you can understand from the history itself. There will be snoring, witnessed apnea during the night, excessive daytime sleepiness. Primary aldosteronism, I already mentioned, elevated plasma aldosterone renin ratio. It will be a very high. We can know the mechanism is that primary hyperaldosteronism. The aldosterone from the medulla is very high. So it leads to higher value compared to the renin. So the ratio will be very high and potassium will be very low. CKD, we can just monitor the creatinine. Renal artery stenosis, young female, atherosclerotic disease, pheochromocytoma, episodic hypertension, palpitation, sweating. Cushing syndrome, clinical appearance of moon phases, central obesity, striae, coactation, I already mentioned. So All these secondary causes, the prevalence already also is also mentioned here. It's almost 8% for the kidney disease. And treatment for kidney patients, the best thing to start with would be an AC inhibitor or ARB. But you should ensure that his renal function is not worsening more than 30% with your starting of telmisartan or enalapril. Renal artery disease, I had told. So angioplasty, the issues I had told. Hyperaldosteronism, the patient might just tell of fatigue, might be due to hypokalemia. So you give aldosterone antagonist or also AC inhibitors you can give. Pheochromocytoma, the treatment we already dealt with alpha blockers followed by beta blockers. Cushing syndrome, surgical intervention. Hyperthyroidism or hypothyroidism. It is told that hyperthyroidism leads to increased systolic BP and hypothyroidism leads to increased diastolic BP. Sleep apnea, the CPAP therapy, and coarctation needs the angioplasties. So to summarize, I had described a very rare possibility of a hypertensive emergencies and the approach we had thought of and how we had managed. But that's not the takeaway from this class. What I would like to emphasize is that hypertensive emergencies can affect your organs in many ways, and we should target the treatment according to the specific diagnosis. And we can use the parenteral agents like labetalol or nitroglycerin or nitroprusside. We should not overly reduce the BP and leads to hypoperfusion. And also, resistant hypertension is very common. It might be due to correctable factors. It might be due to secondary hypertension. And secondary hypertension is very unmanageable until the correct etiology is diagnosed. And very importantly, not only for secondary hypertension or hypertensive emergency, combining pharmacological agents from various classes with different effects. I did in detail regarding that, but you can just remember by this short form, ABCD, AC inhibitors, beta blockers, calcium channel blockers, diuretics. So AC inhibitors leads to vasodilation, and also they counteract the renin-angiotensin mechanism. Beta blockers reduces the heart rate, reduces the systemic vascular resistance, and also calcium channel blockers. They are vasodilators, so they leads to peripheral vasodilation, reduce the peripheral resistance, and diuretics. They reduce the intravascular volume and also they reduce the resistance. So A, B, C, D should be the first line agents. We usually tell that the beta blockers is little down the line. So A, C, D, beta blockers. Then only the second line agents like our arcamin, prazosin, minoxidil, hydralazine, isoleucine. All these are not wonder drugs. They should be used when you're failing on the primary drugs because they have higher side effects. And when you're writing a prescription for any routine hypertensive patient, just think of what mechanism of action will this drug have. And when you're combining two drugs, the effect is much higher than just doubling the dose of a single drug. And you will reduce the side effects also. So, and also ensure that your patient's target BP is controlled. You should not be happy with a 160/90 because the patient is asymptomatic. So resistant physician should not be there in treating hypertension. Thank you.
Thank you, Dr. Tom, for the excellent and very informative talk. The topic is open for discussion.
Yes, sir.
How often you did?
Actually, we had the negative predicted value of plasma metanephrine was told to be around 95%. 95%. So, but we think we couldn't find any other possibility because explaining the situation. Only in 5% case only it will be negative. Only 5% case it will be only negative. So, but it was a paraganglioma, so we might think some. Initially, BP was also very well controlled. So we were thinking that some episodic presentation of the disease. That's how we were explaining that. Yes.
Even what is the cause of disease? People
Yes, sir. Diabetes was only new onset also. There was no evidence of any diabetic retinopathy. His BP was the main issue which he was having. For 2 years, previously he was not normal, not on any BP drugs. 2 years only he had all these issues of BP. His BP was the main culprit before behind the rise of his renal function. So his kidney, CKD, we were attributing due to hypertension across sclerosis.
You mentioned that surgery was done in the kidney.
It was clear to renal carcinoma. We thought of relating everything.
No evidence of suprarenal.
No, it was nothing like suprarenal. It was purely lower pole mass, and it was clear cell carcinoma. We had been spoken about before.
Even though it's not relevant, medically we can suspect millions multiple endophthalmitis. So can be factors, and
Yes, sir. That was one possibility. We had thought of the hyperparathyroidism with the fibrosity, but his calcium and PTH levels were all normal. Yes, men syndrome should be thought of when you are getting a pheochromocytoma. That there might be many things to it. This one. Yes.
Will be advised by a nephrologist, I believe. Dialysis will be advised by a nephrologist.
Yes, sir.
Was the cause of dialysis assessed that time?
Also,
Why went for chronic kidney disease?
yes, sir. As I have shown in the slides, prior to this presentation itself, this resistant hypertension was evaluated. So at that time, renovascular causes, hyperaldosteronism, even pheochromocytoma was evaluated at that time. But they couldn't get anything at that time.
Radiologically?
Radiologically, they did the ultrasound imaging only. That didn't show anything at that time.
Okay. So if this patient goes for this dialysis, and you said that this patient, bystanders, they're ready to spend any money for any medicines. If they are ready for a renal transplant, if they go for a renal transplant, will this patient end up with the same problem?
Yes, sir. His current presentation was due to a flare of his pheochromocytoma, clear diagnosis of histology. So even if he had done a transplantation, that wouldn't alter his course. He would still have had a high BP and this low sugar issue, whether it be dialysis and whether it be transplant. And this possible option of transplant.
Thank you, Dr. Tom Jose Kakkanattu, for accepting our invitation. It was a very good presentation. I felt it were a movie. Just we were watching a movie. It was simple and clear and lucid presentation. Thank you. Thank you all the members for attending the talk. Thank you.